I would like to thank AMP for allowing me to be part of this virtual AMP this year. I would like to start by introducing my topic for this talk. So the topic of my talk today is time consumption for performing CLI interventions. These are my disclosures. So when we talk about critical ischemia, we are talking about Rutherford class 5 and 6, a patient with gangrene and very end-stage disease. When you look at their angiograms, almost all of them, they have a very complex anatomy, a lot of CTOs, chronic calcific occlusions. So treating these patients definitely takes more time, more efforts, more energy. So I like to talk about how can we treat these patients as an interventionalist or CLI specialist by cutting down our time and consumption. Some sort of a way of doing this without getting really, really exhausted, or places we can save some time. So let's start with some different factors. I divided into patient-specific and then procedure-related factors. These patients are very sick. As we know that they have multiple comorbidities, which makes them high-risk patients to start with. Now, procedure-related issues, all of us, we know that the patient with critical ischemia, they have multi-segmental occlusions. They have infrapopliteal occlusions, which is much more common, and they are very calcified occlusion. They're smaller vessels. And we do have a limitation in treating them because there's certain things which we can do for SFA, we cannot do for TBLs, like subintimal angioplasty for heavily calcific vessels. Very difficult to re-enter. So we try to stay in the lumen and get through to this long CTOs. So it takes more time and expertise. Again, we go all the way down to below the ankle disease, because the target organ is the foot. So we end up doing interventions to the plantar vessels, dorsalis pedis, pedal loop. Again, just trying to say that the treating patient with critical ischemia is much different than just doing peripheral arterial interventions in a general term. So if you look at the entire time which is spent during this procedure, where there's a time spent on diagnostic images, then access to the interventional site. I'll talk more about that. And then crossing the CTO takes quite a bit of time, and then post-CTO interventions. Time-saving recommendations, these are some of them which I think they're very important. Pre-procedure considerations, anesthesia. Does the patient need anesthesia? Why? Because is he moving too much? It's going to be a long procedure. Is the patient is demented? He has a restless leg syndrome or somewhere. You're going to be very uncomfortable doing the procedure. It may take longer time. Positioning of the patient, I will talk a little bit more. What is the best positioning in case we have to do alternative access or 2 or 3 accesses? And then what are different techniques I'm going to use to cross these CTOs? Positioning patient, mostly, almost always the patient should have entire leg prepped, so that in case we have to go to the second access or third access is ready to go. And again, positioning the patient always should be in your mind. If the first antegrade access fails, you have to go to retrograde access, then you should be positioned the patient in a way that is very easy to get to the access. What is an access? What is an optimal access? Let's talk about now that. Is it a contralateral access is better than an antegrade access versus SFA, common femoral, or retrograde accesses? These are some of the examples. This is an antegrade access by French. I almost always use this access when I'm doing infrapopliteal, popliteal, or distal SFA lesions, because it gives you a really good supporting and torqueability to the vessel and pushability if you compare this to the going up and over. Retrograde access, we talked about all the tibial vessels or distal SFA, distal popliteal. I strongly recommend to do under ultrasound guidance. There's many, many advantages of it. There's no radiation related to it. It's a real time. You can see where your wire is going. And so these are some of the examples here. You can see that PT, peroneal, and AT axes, and you can see these are all connected with the tubings so that we have a continuous infusion of a fluid called Tamifluid, which has a heparin nitroglycerin to prevent spasm or thrombosis. These are some of the different other axes. This is a distal SFA axis where we are going retrogradely from here. This is a distal popliteal axis going retrogradely going up. So these are the different axes. It just depends upon the anatomy, where the disease is, where the CTO is, and what's the ideal axis. So all depends upon the pathology. Crossing CTOs, all of us, we have different ways of crossing CTOs. Only my recommendation would be that to just find few wires and few catheters which works for you and just be comfortable with that. And then there are different techniques, intraluminal or extraluminal reentry devices. We call it north meets south techniques or transcollateral techniques. We can use that. Now, my recommendations to crossing the CTO, first of all, is we call it fail fast, meaning that once you're getting through you're going through the CTO, you think you are unable to cross, don't spend much time because you're going to waste time, contrast, radiation, just go to plan B. Fail fast, go to plan B. If that means going to pedal or popliteal, go there. We call it tibials are your friends. Use them. It will make your procedure very successful in many cases. So if we do all these things, so diagnostic images time stays the same. You can cut down significantly by deciding right from the beginning what access you're going to make, going to get, and then crossing the CTOs by utilizing different approaches, plan A, B, C, alternate access. Definitely you can cut down the time of crossing by half what you usually do. And then the rest of the time will be post-procedure interventional, post-CTO crossing interventional procedure. So if we use this strategy, you can reduce patient fatigue, less contrast and radiation, and comfort. This is one of the patients I have, has a CLI, long occluded SFA, and also occluded popliteal. I went through anti-gradely and unable to get through, as you can see that. So I decided to go retrogradely. This is a retrograde injection. And retrogradely, again, I was not able to get through to the lesion. So I went to distal SFA access. Here you can see that we have a posterior tibial access. I have a distal SFA access. And then using these techniques, I was able to get through to those long CTOs, followed by directional atherectomy. And then this is the final results, totally healed. So in conclusion, a proper case planning is very important. And then sound CTO crossing strategy to significantly reduce your time, which can lead to less fatigue, less contrast, and radiation exposure. Thank you so much.